and starting the session. Good evening and welcome to one and all. Myself Rupsha from Planet. The designated session assistant for a seamless experience of the session. Clarinet is very proud to be a digital partner of this event organized by Cancer Kids Strength of Smiles Doctors Network Maharashtra. And the topic of today's session is Lecture 6, Approach to Lymphadenopathy in Children. Clarinet is India's most trusted, widely used digitech platform with multiple enriching services exclusively for doctors. So let's begin today's session, for which I would like to invite Dr. Monica. Over to you, ma'am. Kindly proceed with your talk.
Thank you, Rupsa. Please allow me to share my screen.
Sure, ma'am. You can do it by yourself.
Okay, done. I'm doing it. So I hope my screen is visible.
Yes, ma'am. Just make it full screen. That's it.
Yes, so good evening, everyone. So we are doing these lectures, and I think it is we are having a great experience and a great interaction in the end. So today's topic is approach to lymphadenopathy in children. So this topic was thought because so most of the lymph nodes in children are not always significant, but once they are significant, we need to find the reason for that, and we need to maintain a balance in doing aggressive management to reach a diagnosis. So that was the whole thought behind this, and we then started. We proposed this topic. So first speaker is Dr. Manas Kalra. He's senior consultant in Sir Gangaram Hospital, Delhi. He is a gold medalist both in MBBS and MD Pediatrics, and has done fellowship from Children's Hospital, Australia, in Sydney. Dr. Manas, I'll hand over the screen to you. I'll just stop sharing. Dr. Manas? So can you just check with Dr. Manas? Is my this thing? Can you unmute him from your side?
Let me check, ma'am. I think sir has disconnected because I couldn't search him. Did he logged in by his name?
I think so. I'll just call him.
No, I couldn't find him.
Can you hear me, ma'am?
Yes,
sir.
Sorry for that. Is my screen visible, ma'am?
Yes, sir. Yes, sir.
Okay. Okay, thank you, Dr. Monica and team for this opportunity. Today, I've been asked to speak on approach to a child with lymphadenopathy. So, we are a group of 3-4 people who will be discussing this main topic on lymphadenopathy in children. And, we have kind of divided our talk into various aspects of lymphadenopathy in pediatric age group. So I'll cover on few aspects of lymphadenopathy. I hope my screen is visible and I'm clearly audible.
Yes, sir, you are.
Okay. Thank you. So, by definition, lymphadenopathy is enlargement of lymph nodes, and it may be physiologic or it may be pathologic. So you can have a little bit of lymph nodes in every child And sometimes, just small, tiny lymph nodes are not very significant, but sometimes, there is a lot of panic that is associated with this benign small lymphadenopathy. When we talk of a pathologic lymphadenopathy, it can be increase in the number or the abnormal consistency, and also the size of the lymph nodes can be abnormal. So 30 to 40% of the children have lymphadenopathy, and almost, a grown-up adult has 400 to 450 nodes, which can be there in an adult. The classification of lymphadenopathy can be done based on the size, on the site. So you can have a regional lymphadenopathy where only one site is involved, or you can have a generalized lymphadenopathy, and I'll come to the definition of that. It can also be classified based on the duration, which is acute, subacute, or chronic. So when we talk of acute, lymphadenopathy, usually this kind of a lymphadenopathy happens by, different types of infections like streptococcus, staphylococcus, which is the typical suppurative lymphadenitis. You can have viruses like EBV, adenovirus, or you can have anaerobic bacteria, which can cause lymphadenopathy, usually because of dental issues. This acute lymphadenopathy usually, presents, we talk about this when the lymph node has come up within like 2 weeks. Then when we talk of 2 to 6 weeks, and some people like to call it 1 to 6 weeks, then it is usually subacute. And beyond 6 weeks, it's usually chronic lymphadenopathy. Now, subacute, again, the primary cause is often infections, and you can have streptococcal infection, tuberculosis, you can have autoimmune diseases, malignancy, and viruses, EBV constitute to be a big important cause. Sometimes simple things like lice in the hair can lead to lymphadenopathy. Dandruff, bad dandruff can lead to lymphadenopathy. Leukemia, lymphomas, neuroblastoma can also present with a subacute lymphadenopathy. Usually you don't have a very short history, but nowadays we see leukemias, with 5-6 days history also, because the awareness is increasing. And also lupus, autoimmune diseases like lupus can present with subacute lymphadenopathy. Now, chronic lymphadenopathy again can be seen with conditions like infection. So tuberculosis stays as the #1 cause in India. HIV, Hodgkin lymphoma, leukemia, lymphoproliferation, which can be seen in conditions like immunodeficiency. You can have Rosai-Dorfman syndrome, thyroid cancers, and these conditions can also have a chronic lymphadenopathy. And this list is clearly not very exhaustive. When we talk of history in these patients, we always want to know about the duration of lymphadenopathy. But also we want to take simple history like history of sore throat, recurrent throat infection, mouth breathing, noisy breathing, mouth ulcers, sinusitis. A bad sinusitis can also lead to lymphadenopathy in children. And by far, these are the commonest conditions. And a pediatric hem-oncologist doesn't have to be involved in such conditions. History of dental issues, eye or ear infections, history of lice, dandruff, history of pets, or exposure to animals. So one of the conditions like cat scratch disease caused by Bartonella can lead to lymphadenopathy, and history of contact usually is helpful. If a child is walking barefoot, he can have inguinal lymphadenopathy, and that may not be very important. We always want to ask history of B symptoms, and this is very important, not only from the point of view of Hodgkin lymphoma, but actually it can be seen in many, many conditions. But the prototype is Hodgkin lymphoma, and the definition is very clear, where the weight loss has happened for more than 10% within the last 6 months. So you want to ask history of recurrent persisting fever, and you want to also ask about history of drenching sweat. So this is again a common history that you would want to ask in any patient. You would like to know if there are swellings anywhere else in the body, and you would examine a patient for that. So sarcomas can present with swelling somewhere else, and you can have a regional or a distant lymphadenopathy. History of ptosis can be seen with neuroblastoma. You want to ask history of drug intake. So some of the drugs like phenytoin is associated with lymphadenopathy, and it's a common side effect of this drug. Phenobarbital, carbamazepine, aspirin, cyclosporin. We had a child, you can see in the image, he was taking cyclosporin as a part of immunosuppressive therapy for aplastic anemia, and he did have a significant lymphadenopathy. Penicillin, tetracycline, cephalosporin, Sulfonamides and INH can also lead to lymphadenopathy. So a drug history is also very important. A death of a family member, a death of a parent may point towards a immunodeficiency or retroviral disease, or it can also point towards some hereditary cancers, and these are very important history that we need to take. You want to look at the size of the lymph node, and that is very important when you're examining. So a significant lymphadenopathy usually is when you see a cervical lymph node more than 1 centimeter, an axillary more than 1 centimeter, inguinal more than 1.5 centimeter, any epitrochlear lymph node or popliteal lymph node or a supraclavicular lymph node is significant, and usually less than 0.5 is not what you would really be able to appreciate. So if these lymph nodes are present, this patient requires evaluation. Whenever you are examining a child with cervical lymph node, try to palpate the patient from behind. And I know that these rules don't really stick very well for children, because in children, you have to just examine them in the position of comfort, by bending the neck, head forward, relaxing the muscles, a gentle flexion towards the side. If you want to examine towards one side, gentle flexion kind of relaxes the muscles. You want to look at the pre-auricular and the post-auricular first. And then from the front to the back, you want to look at submental, you want to look at submaxillary, you want to look at tonsillar nodes, and then you want to look at the occipital nodes as well. And rare diseases like rubella, etc., can have these lymph nodes which are involved. Then when it comes to the neck, you want to examine the anterior cervical and the posterior cervical chain, and you want to look at the supraclavicular lymph nodes. So, in adults, usually this pattern is quite clear. You can very clearly see the submental, the preauricular, the tonsillar area, the submandibular area, the anterior cervical, the posterior cervical, and the supraclavicular. But we all know that being pediatricians, this can be really challenging. So if we know that there is a significant lymph node, that is pretty good. So you can have your own sequence of from where you want to, how you want to examine. But as I said, this rule doesn't really always stay good. So a left-sided Warshaw's node or a supraclavicular node, the enlargement of this is called Trocheus sign, and we have all read that in our graduation and post-graduation. And it is important that we don't miss this when we are examining a patient, because this takes supply from the lymph vessels in the abdominal cavity via the thoracic duct, and are therefore sentinel lymph nodes of cancer in abdomen. So you might have a supraclavicular node, but the disease can be a primary neuroblastoma. So these can be enlarged in patients with neuroblastoma, Hodgkin lymphoma, gastric cancer, ovarian cancer, which are not common in children, testicular cancer, and kidney cancer. Enlarged right supraclavicular node is usually seen with Hodgkin lymphoma or thoracic or esophageal malignancies as compared to the left-sided supraclavicular node. So we need to worry about some nodes. Especially they can be either malignancy or they can be granulomatous lymph nodes. So usually the symptoms are a kind of little more prolonged. A supraclavicular node is always pathological. A generalized lymphadenopathy requires a detailed evaluation. Presence of B symptoms require detailed evaluation. A fixed non-tender node is important. Matted nodes are usually seen with tuberculosis, but they can also be seen with lymphoma, especially non-Hodgkin lymphoma. Non-tender nodes are more worrisome as compared to tender nodes. And obviously, if you have abnormality in blood, in your chest X-ray, a very high LDH, these are some things worrisome. And if you cannot find a focus, so absence of symptoms in ear, nose, throat, and a persistent elevated ESR-CRP makes us worry more. Coming to the prototype disease, which is Hodgkin lymphoma, usually they have a long-standing lymphadenopathy, and the most common site is cervical. The typical feel is that of a rubbery feel. They are not really attached to the deeper structures. Usually sinus formation is not seen, but in India we have seen very massive lymph nodes even with Hodgkin lymphoma because of delayed presentation. And the mediastinal nodes usually do not cause airway obstruction as compared to the non-Hodgkin lymphomas, which lead to airway obstruction, and this may be associated with hepatosplenomegaly. So what is positive node? Different groups have defined it differently, but for Euronet, a lymph node less than 1 is not involved. A lymph node more than 2 is involved. And in between, if you have a PET positivity, from 1 to 2 centimeter, if the PET is positive, we take them as involved. So, the COG has a little bit of different definition. I've just mentioned it, but I don't want to go in details for that because, it can be confusing. And, just stick to one kind of a guideline, and from 1 to 2, go with the PET and your clinical examination and your, feel for the patient. So, whenever we talk of Hodgkin, this is a beautiful diagram. It is available everywhere. And we kind of group the lymph nodes based on this distribution. And that helps us to stage the patient very appropriately. So, these are some of our patients with Hodgkin. You can see this boy was sitting with this kind of a node, which was growing very slowly for a period of 1.5 years. And this girl who came from Bihar presented with this bad ulceration and was being treated for this ulcer. In fact, the primary disease inside was Hodgkin lymphoma, and after treatment, this completely healed. So we are familiar with the Hodgkin lymphoma staging, but I think no topic of lymphadenopathy will be complete if we don't talk of Hodgkin. And this, simple classifications above the diaphragm, below the diaphragm, and extranodal sites as stage 4 helps you to classify Hodgkin lymphoma. And then, you can look at the extranodal sites, you can look at the spleen, and that helps you to classify Hodgkin lymphoma completely. And we know what are the definitions for bulky disease. So anything more than 6 centimeter is bulky. And when you look at the mediastinum, if it is more than 1/3 of the thoracic diameter, usually this is called as a bulky disease. So we look at all the other sides and we stage a patient, and we look at B symptoms. If they are present, we call it B. If they are bulky disease, we call it X. And if you have a single extranodal site, which is contiguous to a nodal site, so just attached clearly, so those are given the designation of E. So, these are some of the tips. They come very handy. So if you have 2 nodal regions and 1 extranodal region on the same side of the diaphragm, it is 2E. This is where, often the residents confuse. So this is 2E, even if there are 3 different sites, it is 2E. 1 nodal region and 1 extranodal region on the same side is still 2E. Okay, so this is very important. 2 nodal regions on 2 different sides of diaphragm plus the spleen is 3S, because, they've crossed the diaphragm. Cervical nodes and liver is stage 4. So E has to be contiguous with the involved region. If it is non-contiguous, then it becomes a stage 4. So these are some tips for Hodgkin lymphoma staging. Other malignancies which can be associated with lymphadenopathy are leukemias, non-Hodgkin lymphoma, T and B lymphoblastic lymphomas, Burkitt, DLBCL, anaplastic large cell lymphoma, neuroblastoma. I talked about sarcomas, germ cell tumor, LCH, HLH can be associated with lymphadenopathy, thyroid, and nasopharyngeal carcinoma. So you can see this child with a neuroblastoma. This is pre-treatment, this is post-treatment. You can see in the pre-treatment scan the large neuroblastoma, and you can see here the supraclavicular node. I think it's quite clearly visible, and after treatment, that supraclavicular node has disappeared. Now, this is a child with Burkitt's lymphoma, and this is the pre-treatment scan, the lower one, and this is the post-treatment scan where the lymph nodal mass has kind of disappeared. So it arises usually in the pair patches areas, and many other lymph nodes can get conglomerated with that. So, these are the traditional differences between Hodgkin and non-Hodgkin lymphoma. They don't always stay, true, but Hodgkin lymphoma is a lot of, nodal disease, whereas a non-Hodgkin can have a lot of extra nodal areas. The lymph nodes are larger, but we've seen very large Hodgkin nodes also. Usually the pattern is slow in Hodgkin. They are rubbery in cases of Hodgkin. They are matted more often in non-Hodgkin, and they may have some local inflammatory signs in non-Hodgkin, and you can have Walder ring involvement more common in cases of non-Hodgkin lymph nodes. And abdominal nodes, you can have early involvement of mesenteric in non-Hodgkin and early involvement of para-aortic in cases of Hodgkin lymphoma. So these are some of the differences, but they don't always hold true. So this is a child with a rapidly enlarging, neck lymph nodes, and it turned out to be a T lymphoblastic lymphoma. So anything which comes into the neck, mediastinum with a very short history, usually it's a T kind of a disease. Now, nasopharyngeal carcinoma, I just want to spend a couple of minutes in nasopharyngeal and thyroid because they are very typical and their presentation with lymphadenopathy is very important. So this disease is more common in China, and this is one of the cancers where there is squamous cell carcinomas where there is highest preponderance for lymph nodal metastasis in the head and neck area. And most of the time they are bilateral, they are hard, and they are not mobile. And the lymph node regions include lateral retropharyngeal nodes and level 2 nodes with an overall probability of 70% almost, cases having the involvement of these nodes. And certain cervical nodes like level 1, level 6, para-aortic, supraclavicular, the risk is very low. Only in very extreme cases you see them. And then, you obviously have to look for distant metastatic. You can see in this image down where, this disease is kind of hidden. So once you have looked at the lymph node, you biopsy it, you find squamous, and then your search starts, and then you kind of identify nasopharyngeal carcinoma in children. When we talk of thyroid carcinoma, again, this is rare, but an important underlying etiology for lymph nodes, and especially in the neck. So mainly in children, we have papillary or medullary. Papillary, you monitor it with thyroglobulin level. Medullary, you look at CEA and calcitonin, and it can be associated with MEN syndrome. But lymphadenopathy can be present in both the cases. So you do a neck ultrasound and you do a FNAC guided lymph node, you do a ultrasound guided FNAC from the lymph node, and you can identify thyroid cancer. And then, you have to do a neck dissection for these cases if the lymph nodes are positive. And it is usually from level 2 to level 6, and level 1 is kind of spared. And lymphadenopathy is not really a very high risk factor. It is a moderate risk factor when we talk of thyroid cancers. Another very important disease where we talk of lymphadenopathy, significant lymphadenopathy in children, is Rosai-Dorfman. So it's a non-Langerhans cell histiocytic condition, and it is characterized by accumulation of activated histiocytes within the affected tissue. It is a heterogeneous entity, and it can have association with autoimmune, hereditary, or malignant condition like HL, NHL, and MDS. So all these conditions can have a little bit of Rosai-Dorfman-like picture in them. And a lot of genetic work is being done to understand the pathways. And mainly the problem is the sinus expansion with the large histiocytes that have a watery, clear cytoplasm in them, and a large hypochromatic nucleus with very prominent cytoplasm. The lesion is typically S100 positive, but CD1A negative, and that is what differentiates it from LCH, and you can have a variable degree of emperiopoiesis. So what is emperiopoiesis? There is inside, around, wander about. So this is how the origin of the term is. So you will have an active penetration of one cell by another, which remains intact, and it is not really killed by the lysosomal enzyme killing, and it can exit anytime without any damage. And you can see this emperiopoiesis happening, and it can be physiological, but in RDD, this is one of the typical findings that you identify. It mainly affects young adults and children, so important DD for us. And you usually have a bilateral, painless, massive cervical lymphadenopathy. Mediastinal, axillary, inguinal can be there, but retroperitoneal lymph nodes are generally rare, and you can have extranodal disease in around almost 45% of the cases. So Castleman disease is another important differential for big lymphadenopathy. What happens in these conditions is a non-clonal lymphoid hyperplasia, and some call it a angiofollicular lymph nodal hyperplasia. It is exaggerated changes to normal antigenic stimuli by some viruses, autoimmune phenomena, or by neoplasm. And it is a low-grade kind of neoplastic process, some people call it. And you can have hyaline vascular and plasmacytic variants, and you can see onion peel appearance or a lollipop sign, and I'll show you images of that. So Castleman, if it is unicentric, you can just treat it with surgery. Multicentric variants are generally associated with HHV8 or HIV infection. And you need treatment with varied agents. Sometimes you give them antivirals, steroids, because the pathway goes through the IL-6. In bad cases, in the multicentric aggressive cases, you may need IL-6 inhibitors, chemotherapy, rituximab, or even radiotherapy for these patients. And this is the typical lollipop sign and the onion ring sign that you see in the histology of these patients. Another important differential for lymphadenopathy is Kikuchi disease. So this was first reported in Japanese patients by Japanese pathologists. And they are tender localized lymphadenopathy, and the patient can be very symptomatic with fever and night sweats. So again, it's an immune response of T cells and histiocytes to some kind of an infection. More commonly, there is a posterior cervical lymphadenopathy in young females. It is idiopathic, it is a benign condition, and you can have varied, triggering factors for this. What you see is a lot of necrosis, fragmentation, and karyopexis in biopsy, and you can treat them with anti-inflammatory, steroids, and IVIG in most cases. Sometimes we have to use anakinra also for these patients.
Dr.
Another
Manas,
important-
sorry to interrupt. How much time more will you take?
I'll finish within 5 minutes, ma'am.
Yeah, thank you.
Okay, so sarcoidosis is another medical condition which can be there in patients with lymphadenopathy, usually seen in children and young adults. And you can have some classical signs, skin manifestations, erythema nodosum, but uncommon in children. But sometimes we come across this condition when we are evaluating children with lymphadenopathy, and an elevated ACE and eventually a biopsy is what kind of picks the diagnosis for sarcoidosis. When we talk of infections, and I will not go into details for that, you all are aware of bacterial, viral, parasitic, and fungal infections. In fungal infection, important reason is histoplasmosis, and toxoplasma is an important DD when we talk of parasitic reasons for lymphadenopathy. We have already talked about viruses, and a lot of bacteria also can present with lymphadenopathy. This is a child with a bad fungal infection leading to this massive lymphadenopathy, and this was a child who was immunocompetent. Infectious mononucleosis is another important reason for lymphadenopathy in children. It is called glandular fever caused by EBV. In the developed world, seen in older children, whereas in LMIC, it can be seen in younger children, and it is a milder disease. You can have a bad sore throat. That is why, because of the way of spread, it is also called Kissing's disease. And you can have varied features, and some children end up with complications in this condition like splenic rupture. You have atypical lymphocytes. You have rash after giving amoxicillin or ampicillin, and you can have splenic hematoma or splenic rupture in these patients. So this is the typical ballerina skirt appearance of these atypical lymphocytes, which kind of stick to the RBCs, very typical of infectious mononucleosis. Another condition which can present with lymphadenopathy in children is autoimmune lymphoproliferative syndrome. There is a diagnostic criteria for this condition, and it usually happens due to FAS defects. This is a type of an immunodeficiency, and whenever you have a chronic non-malignant lymphadenopathy in children, along with multilineage cytopenia or splenomegaly, think of this condition if you have ruled out all the other conditions. So, this is the diagnostic criteria, and elevated B12 level is often helpful in making a diagnosis. There are many autoimmune diseases which can present with lymphadenopathy. There are 4 categories of autoimmune diseases. In arthritis, you have Sogia, which can present with lymphadenopathy. In connective tissue disorders, lupus. In vasculitis, Kawasaki. And in autoinflammatory conditions, you have PAFAPA, which is the periodic fever condition where you can have lymphadenopathy or a hyper IgD. So all these conditions need to be thought of if you have ruled out common conditions. When we talk of immunodeficiency and lymphadenopathy, we can classify them as infectious causes in PID or non-infectious. In infectious, you can have SCID leading to BCG adenitis, common variable immunodeficiency, PIK3 delta syndrome, which is a type of a CVID. EBV triggered lymphadenopathy happens in these conditions. CGD and MSMD, where mycobacteria triggers the lymphadenopathy. In non-infectious conditions, I've already told you about ALPS, and you can have other rare conditions like LRBA, CTLA4, EBV-associated PIDs, or hyper IgM. Now, these are some of our patients like CGD, MSMD, EBV lymphoproliferative, or hyper IgM, which have presented with chronic lymphadenopathy, either infectious or non-infectious. And I'll not take you into the details of evaluation of a PID leading to lymphadenopathy. Just coming towards the end, so storage disorders can also present with lymphadenopathy. And I'm not an expert for that, and I usually get the help of my genetic colleagues. But Gaucher's, Niemann-Pick, mucopolysaccharidosis, oligosaccharidosis, and polyglucosan body disease can present with lymphadenopathy in children. So with this background and some bit of details of hematological malignancies, autoimmune diseases, some of the immunodeficiencies, and rare diseases like Rosai-Dorfman, Castleman, Kikuchi, I would now hand over it to my colleagues to take this discussion forwards on lymphadenopathy in children. Thank you.
So I'm just sharing my screen. I think my screen is visible.
Yes, ma'am, it is visible.
Yes. So next speaker is Dr. Hiren. He is senior consultant in SRCC hospital. He's a pediatric radiologist, and I came to know today only that he was awarded as best student, DNB student in radiology in 2013. Over to you, Dr. Hiren.
Yeah. Thank you so much. Can you just stop sharing? Yeah. So good evening, everyone. So I'll be going through the a brief of imaging, like how it helps in diagnosing of malignant lymph nodes. Just a minute. Yeah. So these are the imaging modalities that we use when we are evaluating the lymph nodes.
Dr. Hiren, your voice is not clear.
Why it is not clear? Now?
Yes, so now it is clear.
Now it is better. Yes.
Okay. Yeah. So these are the imaging modalities that we use in the evaluation of the lymph nodes. The USA is the most basic and initial one. And CT and MRI, these are the cross-sectional imaging modality, which has got more sensitivity as compared to USG, because they have got, we can see the deeper structure as well. And there is definite role of PET CT or PET MRI kind of functional imaging, which aids value in particular cases. So starting with the USG, so we can see that on USG, if you see that there is absence of fatty hilum, and if you see thickened cortex in a lymph node, that is the most specific predictor for the malignancy or metastasis. That I'll be showing you in subsequent slides that how it looks like. And it is very important to detect the fatty hilum, because when you see the fatty hilum in the lymph node, it is more likely to be benign lymph node than the malignant. It is not 100% rule, but most oftenly what we see that I'm talking about. The advantage of USC is that it is easily available, it is radiation free, and it is safe to use. So that's why we use it frequently. Now, there are certain criteria that we see on imaging to categorize as a malignant or metastatic lesion versus benign or non-metastatic lesions. So first of all, you have to see the distribution of the nodes. If the nodes are scattered, they are more commonly seen with benign nodes. If they are clustered together in a localized drainage area or in particular region, then it is more likely to be a metastatic nodes. That is quite explainable. Then size, Dr. Manas has already touched, but just to have a brief that the size of the lymph node, whether what is the cutoff to tell it as abnormal or pathological, it is a very debatable topic, because sometimes less than 5 millimeter nodules can also have underlying malignancy. However, just to keep the sensitivity and specificity optimal, these are some rough guidelines that we can use. If it is a case of neck, then less than 1 centimeter or 1.5 centimeter in a case of level 2A is considered as a benign looking nodes. But we have to check for other criteria also and other the characteristic of the nodes on imaging. And in the chest, if you see the node size less than 1 centimeter, that is benign, and more than 1, that is more likely to be malignant or metastatic. In the abdomen, if you see the size of the lymph node cutoff is again 1 centimeter. And in the pelvic area, the cutoff is 0.8 centimeter. Then you have to see the shape of the node. If the shape is more oval shape, that is more likely to be benign. in comparison to round shape that is in malignancy. And the texture on imaging, if it is homogeneous, then it is likely to be benign in nature. And if it is heterogeneous, that is more likely to be malignant. You have to see the margins of the nodes. Margins are regular, it is likely to be benign. And irregular, that is considering as a malignant. If the capsule is intact, that is a feature of benign nodes. If there is some sort of extracapsular spread, that is more likely to be metastatic disease. You also have to see the border of the node. If it is well defined, it is benign. If it is ill defined, that is not normal, and that is more often seen with the metastatic nodes. Then you have to see the calcification also. If the calcifications are microcalcification, that are seen more often with the malignant nodes. For example, papillary thyroid carcinoma, these are having more calcification. And you have to see this absence of hilum. That is more important. So whenever you see absence of hilum, you should start doubting that this node doesn't look like normal. It can be metastatic. Even though it is small in size. Then also, if you don't see absence of hilum and cortical thickening, that makes a lot of sense. And if you see necrosis can be seen in infection also, but it is not seen in physiological node. And if you see it, then it is likely that we are dealing with some sort of metastatic or malignant node. So I'll be showing some examples on USG. So that's how on USG, benign looking nodes look like. So that's the oval shape, and it has got this kind of central fatty hilum. So that is the normal structure of the lymph node. And these are a lot of pathological cases that I'm be showing about. So here, if you consider that the shape is oval, but if you are not able to see the central echogenic hilum, so that is indicative that there is loss of fatty hilum, which can indicate this can be early stages of or early infiltrative metastatic disease. And when you see this kind of enlarged nodes with lot of perinodal vascularity, and you see this kind of irregular margins, that indicates there's some sort of capsular breach, extra nodal spread, and it looks aggressive. This kind of nodes, it can be seen in infective condition also, but the history will be different. And sometimes suppurative node can have this kind of appearance, but they will have different kind of clinical history as compared to the cases with the malignancy. These are a few other more examples. You can see that these are the microcalcification which I was talking about. In a case of thyroid carcinoma, you can see this kind of tiny echogenic foci which are indicative of microcalcification. And if you see this kind of hypoechoic, like fluid kind of signal intensity area, that indicates necrosis within the lesion, which is also a common feature of malignancy. Of course, it can be seen with TB also, but you have to see in the clinical context. Now coming into Doppler. Doppler also can be useful modality to assess whether the node looks like to be benign or malignant. For example, if it is a benign node, it will have this kind of central hilar vascularity. In the case of malignancy, you will see that the central vascularity may not be there. You will see this kind of peripheral marginal vascularity, or it can be intra-lymph nodal vascularity, but not through the hilum. So that indicates that it looks like more of a malignancy kind of appearance. There are certain features in particular scenario. For example, lymphoma case, if you see this kind of reticulation, if you see this kind of pseudocystic appearance, and if you see this peripheral and hilar nodes, that hilar vascularity, that indicates it that you might be dealing with the lymphoma. So lymphoma nodes will be multiple, they will be more than 1 centimeter in size. They are homogeneous in appearance, and they are hypoechoic. Hypoechoic means they are dark on ultrasound. Now moving on to the next modality, that is CT. CT, again, we look for the same criteria. In addition, we also see enhancement pattern, that is the other additional criteria that we can see on CT. So here is the advantage or the example of cervical node. And we can see this central hypodensity, that is the hilum of the that cervical nodes. It is the level 2A. So just to show you that how the normal morphology of the node looks like, it's almost isodense to the next this skeletal muscles that we can see. This is the sternocleidomastoid muscles. The density is almost similar to that on CT scan. So again, that's size criteria. So in a case of malignancy, we recommend that irrespective of location and NH, 10 millimeter in this short axis diameter. Short axis diameter means like the diameter which is lying shortest from one cortex to the outer cortex. Like this diameter, if it is crossing more than 1 centimeter, then it is considered as a pathological. And if it is more than 50 millimeter for long axis diameter, then it is considered pathological. Now, with the, like, due to interest of time, I might not be showing you the anatomy. If the time permits, and at the end of the session, I can show you this kind of cervical adenopathy, how to detect the stations. Now we'll be seeing some certain examples of pathology. If you remember the previous slide, the normal nodes will be oval in shape. Here we are seeing that now the nodes look like more of a round or elliptical shape, and they are enlarging in size. But you can see that the enhancement is almost homogeneous. We are not seeing any inhomogeneity or areas of necrosis within the nodes, and the nodes are discrete. So these are the classical features of lymphoma that you can see in a case of Hodgkin or non-Hodgkin lymphoma. They have similar kind of appearance, and you cannot actually differentiate based on imaging 100%. And as Dr. Manas also has mentioned, that sometimes you will see a nodal mass which is having hypervascularity. So just to show you that this is a plain scan and this is the post-contrast scan, these are the CT scan at the level of chest and the anterior mediastinum. We are seeing this kind of intensely enhancing mass lesion that is showing increased arterial flow. That is one of the classical features of this Castleman disease, which indicates angiolymphoproliferative disorder. Sometimes you will see necrosis within the nodes that can be seen in malignancy more often, but you have to always keep in mind that can it be TB. So this was the example of TB, in which you can see that nodes are conglomerated and they shows multifocal areas of this hypoadrenating within that node, which is indicative of necrosis. And TB also can show this kind of calcification on treatment or when they heal. So that you should keep in mind. These are the same patient, different views showing the necrosis and the conglomerated appearance. So that is highly predictive of TB. Then another question that is often asked what is when we consider mesenteric nodes in the children pathological, because we often see a patient coming with the mesenteric adenitis or non-specific abdominal pain, and we can see these kind of mesenteric nodes so often. So that's not pathological. So when you see that the node size, if it is more than 0.8 centimeter, that is the cutoff in children that we can label it as a pathological or not looking like normal kind of nodes. And if they are in clustered and if they show the change in morphology like more round in shape or they show necrosis and more than 0.8 centimeter in size, then that is looking abnormal. Then there are certain conditions which can have metastatic adenopathy, which will have calcification. So this was the example of neuroblastoma in the right hemithorax paramediastinal region. And the patient also had this kind of this subcarinal node, which was showing calcification. So when you see calcification, it's not always TB. There are certain malignancy which can have this kind of calcification that you have to keep in account. When you see this kind of coarse and chunky calcification, and then you have to go with the history that this was the case of calcified granulomatous disease. So not all calcified nodes are malignancy, that I wanted to make a point. And we often have seen that those patients who are thalassemia, when they have undergone recurrent blood transfusion, they also have slightly increased density on CT because of probable iron deposition in those nodes. So that also, they can appear as a hyperdense on CT scan, on non-contrast scan. So that is not pathological, or that is not malignancy. Now, moving on to the next modality, that is the MRI. So the MRI has greater spatial and the soft tissue resolution. So that can add as more structural diagnostic information. This is very useful when you are dealing with small nodes, especially in the pelvic malignancy, when you want to see the internal iliacs and obturator nodes, and you want to see the node relation with other adjacent structures. Then in that case, MRI can be very useful. So these are the MRI images of cervical region, and you can see that on MRI, the nodes looks like this kind of homogeneous, again, oval shape. They also will show similar central hilum, which will be bright because it contains fat. So it will be bright on T1 and T2. So that will be seen as a hyperintensity linear structures going in the center of the node. So that is normal appearance. Sometimes diagnostic dilemma comes when you see node-like structure in the neck on USG and you are not sure what is happening. So in those kind of scenario, MRI can be useful. And it is the same case in which MRI was done, and there was some lesion which was adjacent to the carotid vessels and encasing the carotid vessels. But on MRI, we could see that the lesion was having this kind of stalk-like structure, which was continuous with the thymus. So actually, this was the cervical continuation of the thymus, which can mimic as a enlarged adenopathy, or which can be mimic as a mass. So in this kind of doubtful scenario or diagnostic dilemma, the MRI has definite role to differentiate from the pathological conditions. One more thing, that MRI has got this kind of functional information also. So this is these different weighted images. So the role of these different weighted images is that the malignancy see they have more cellular to cytoplasmic ratio. So those structures which has more cellular to cytoplasmic ratio, they will show restriction of Brahmin movements, and that will lead to high signal intensity on DWI and corresponding low on ADC. So those nodes, even though they are less than 1 centimeter size, if they show restricted difference, that can be pathological. And this was the example of pathological node where it's better picked up on CT. Better picked up on MRI. So DWI can show this kind of better pickup of smaller nodes which can be missed on CT. Now moving on to the few more facts that there are some certain novel MRI contrast agents have come which can be useful in detecting small nodes. One of them is this ferromoxotran, which is the lymphotrophic agent. So when you inject this contrast into the body through the IV, what will happen that this contrast will be uptake by the normal reticuloendothelial system of the lymph nodes, and those lymph nodes will have macrophages. So those nodes which has this kind of node, they will be suppressed on MRI, and those nodes which are pathological, they will be seen as a bright structures. So these are some new novel MRI contrasts which are coming up in the evaluation of the lymph node. Now coming into the PET. So PET is again it is newly coming modality which uses the functionality of the radionuclide agent. So these are the certain radionuclide agent that we use in practice, like fluorine 18, carbon 11, and oxygen 15. However, the most commonly used the radionuclide agent is the FDG, that is the fluorine fluorodeoxyglucose. So that the funda is that those malignancy or metastasis, they will have high glucose uptake. So that will be seen as a bright signal or increased uptake in those kind of tumor or lymph nodes on imaging. So this is the example of neuroblastoma in the paravertebral location, and we can see that on CT you can see that that mass was arising in the right adrenal, and this is the corresponding increased signal intensity in that region. This is the example of PET CT showing lymphoma, which was having epicenter in the nasal cavity and adjacent maxillary sinus. The patient also had this kind of mediastinal lesion, which was showing increased uptake. So that was the metastatic adenopathy in the anterior mediastinum. Now, a few words regarding the image-guided biopsy. So the role of USG-guided biopsy is very important, especially in pediatric population, because we can save the radiation. The other thing that when we are doing USG-guided biopsy, we are actually seeing the entire track of the biopsy where actually we are tracking. So whenever the lymph nodes are having necrosis or a certain fluid-containing area, that area we can avoid. We can also avoid the area which are highly vascular, so that the chances of bleeding are less. So that is the role of the image-guided biopsy. We can pinpoint the pathological looking nodes, and you can selectively target those areas which are looking abnormal. So these are the example in which we have done FNSC or biopsy from the cervical adenopathy, because they are very superficial, quite easily accessible. Now, just a few words that whenever chance is or if the option is there, you always go for biopsy, because when we do FNSC, we are just taking only few cells from the abnormal looking area. So that is not useful for when we want further information on immunohistochemistry. So whenever the option is there, we should always prefer biopsy as compared to in comparison to the FNSC. This is the example of CT-guided mediastinal nodal mass. So you can see that here is a large mass in the anterior mediastinum, which is encasing the great vessels also, and which shows this kind of areas of hypoattenuation, which is indicative of necrosis. The patient also had this kind of surgical emphysema in the chest wall. So whenever this surgical emphysema is there, we cannot see on USG what is going beyond that air. So in this kind of scenario, it is always better to do CT-guided biopsy, and you can see that CT-guided biopsy can be done under sedation in small child, and you can see that we can see the tip of the lesion, and then we can take safely solid-looking areas of biopsy, and this patient came out to be a T-cell ALL. So to conclude that we have got a lot of imaging modality that we can use in a case of assessment of the lymphadenopathy, in which the USG, CT scan, and conventional MRI, they are the agents which can depict the location, size, shape, and the texture of the lymph node, which can help us to predict that whether it's looking abnormal or not. And we also has got functional imaging modality like differentiated images. We have this kind of novel contrast MRI images, and we have PET images. So they have got more specificity, because if the lesion is showing some sort of positivity on those kind of sequence, that indicates that the chances of being malignancy are higher in those kind of functional imaging modality. And now we have got fusion imaging like PET CT, PET MRI, different with other sequences, and those contrast agent with the other sequences of the MRI. So that helps us in giving the sensitivity more as well as specificity more. So that's the advantage of using this kind of fusion imaging. That is the current practice, and that we should use often in a case of clinical dilemma. So by that, I want to conclude my session, and I would hand over to the next speaker. Thank you. Thank you so much.
This. So our next speaker is Dr. Soumitra Saha. He's Associate Professor in Pediatric Surgical Oncology Department in Tata Medical Center, Varanasi. He has been awarded a university medal for scoring the highest marks in his pediatric surgery. Over to you, Dr. Soumitra.
Yeah, thank you, Monica. Can everyone can see my slides?
Yes.
Yeah. So thank you for this introduction. So basically, I am working in the Tata Cancer Hospital. So my talk, everything will be related with the malignancy in the children and the lymphadenopathy. So, sorry, just make it. Yeah. So the basically the thing is what we discussed from the beginning. The establishing diagnosis is the key. So the treatment can be initiated timely. So it is not only the surgeon, the pediatric oncologist, radiologist or interventional radiologist, anesthesiologist, pathologist, and of course the pediatric surgeon. Sometimes because these all the names I have mentioned, because sometimes the children comes with to us with a very sick situation and need an immediate tissue diagnosis, so the treatment can be initiated as soon as possible. So I'm going to highlight what are the situation, the surgeon's role, the pediatric hematolymphoid malignancy. So provided the adequate tissue for the diagnostic studies with minimal morbidity. So the next thing is the incisional or excisional biopsy of the involved node. Few things from the surgical perspective, the cautery should be judicious so it can minimize the coagulation artifact. So child presented with a cervical or supraclavicular adenopathy, we have to be careful for doing the procedure. See at least the X-ray, what is the status of the mediastinum, because it is sometimes it can be dangerous for the child. So sometimes the child presented with the isolated mediastinal mass, the search should be made for more accessible site, but if not, then definitely you have to take the child for some kind of a local anesthesia in upright position, in the anesthesia with the anesthesia should be there in the OT preferably. So if some kind of thing happens, we should take care of the child immediately. If sometimes if the pleural fluid is there or ascites is there, some needs to be done the aspiration cytology, so we can conclude to some diagnosis and we can start the treatment. Here is a child with a SVC syndrome. We can see there is so much lymph node. The trachea is very, very narrowed, and the skin, subcutaneous tissue are very, very edematous. So this is a very, very critical situation. We have to be careful while going for this kind of a biopsy. So it is always a team's approach. It is not a single man's decision. We have to keep everyone in the loop and go ahead. So now it is kind of a head, neck, thorax. Now is the abdomen. The lymphomas sometimes present with abdominal mass, particularly the NHL. Sometimes they present with intestinal obstruction, features of intersusception can be there. And sometimes they, if they're very advanced, sometimes they present with a perforation also. So always talk with the radiologist if it is possible to get image guided with this, the best, better, because then the treatment can be started as soon as possible. But if it is a difficult area, then go for the open laparotomy or laparoscopic if feasible, please do. Intestinal obstruction, intersusception, sometimes it requires this resection anastomosis. Or if the child is very sick, there's some perforation, better to go ahead with the stoma so the child can be fit for the next line of treatment. Another important issue we come across very frequently, sometimes after the initiation of the chemotherapy, there is some residual mass, and whether this residual mass has the active disease or it is a kind of a necrosis, fibrosis. So it is very, very difficult to differentiate by imaging, or sometimes we use the PET. Here we can see the child of NHL at the time of presentation, which is the left side. Then after the chemotherapy, there is some residual mass, and it is difficult to talk when you talk with the radiologist. It is sometimes they tell it is difficult to target because the vascularity or the bowel loops are there. So sometimes you go for the open laparotomy, small laparotomy or biopsy. If someone is very confident with the laparoscopy, they can do it. Another important thing is a Langerhans cell histiocytosis, where the lymph node biopsy is important. Then, because from the pediatric surgical point of view, other than the pediatric hematolymphoid malignancy, the pediatric solid tumor is also important, where you can need a biopsy. So kind of a nasopharyngeal carcinoma, where Dr. Manas already mentioned, sometimes we can have to do a nasal endoscopic biopsy, or sometimes you can get away with only the lymph node biopsy. Next is the neuroblastoma. This is a surprise. Recently we got a child like this. There is no constitutional symptoms with a cervical lymph nodal mass. But when we did a biopsy, and when they process the specimen, we come to it is a neuroblastoma, and then we go for further investigations. In the PET CT, we can see there is a big cervicothoracic mass is there. Another thing is related with the RMS. It is basically it is the lymph nodal sampling, or it is kind of a FNAC. It is depending on the where we are dealing. If there is a parameningeal, we have to look for the cervical lymph node. If it is according to the size criteria, if it is you can think it is a metastatic, we can do a FNAC to prove it. Even if it is not, FNAC is not inconclusive. So at the time of delayed primary excision, we always try to do a sampling so we can prove it. Yes, the disease is always there. So we can target with the radiotherapy. It is same thing like a upper limb or lower limb, the inguinal lymph node. For the upper limb, the axillary lymph node. We have to sample, and because then they can take this area under the radiation field. Here one child we saw in our hospital is an adolescent boy, orchiectomy done outside, and then presented with a huge lymph nodal mass in the abdomen. So there is the importance of the paratesticular RMS with the retroperitoneal lymph node sampling. So these are the areas you have to go. This kind of cases also can present with a huge lymph nodal metastatic mass. And also Dr. Manas mentioned with the germ cell tumor, other areas also the lymph node metastasis can happen. So it is always at that, I just want to conclude with that, it is not a single man's, one person's decision. We have to sit together, decide what to be the best for the child, and then go ahead with the thing. That's all, Monica.
Thank you, Dr. Saha. I think we have 2 minutes for a case. We can take that. So I'll take only one case, then we'll ask, we have questions from the audience. So, 5 years old a child who was on treatment for throat infection visited pediatrician again because the mother complained that he still had sore throat and was lethargic. There was an episode of nosebleed also, and on examination, child was pale. There was petechiae, and there was the lymph nodes were enlarged, so it was a spleen. So, Dr. Manas, would you just come in and
Yes, ma'am. Yes, ma'am.
Yes. So what should we do?
So this child has got, throat infection. And but the throat issue is persistent, and there was nosebleed, and there are petechiae, and there are enlarged nodes, and there is a spleen. So this is like a multi involvement. It is not just plain lymph node related to sore throat. If the child has a sore throat, why does this child have petechiae? Why is this child pale? And why is there a splenomegaly? So sometimes it can be a EBV infection which can explain all these things. But most often, these are, malignancies. Most commonly in this age group would be leukemia. So lymphadenopathy, splenomegaly, bicytopenias. I would think of malignancy as one of the important differential in this condition. Yes, bad infections can also be like that, but a child who has to have many cell line involvement with a bad infection would be very, very sick. If he's just visiting in a stable condition with all this history, malignancy will be an important DD for me.
Okay, so my slide is not moving. I'll just get back. Yes. So this was the child's CBC.
So yeah, I think we can see that hemoglobin is low. We can see that the platelets are low. We can see that the WBC is very high. So all three cell lines are involved with the blast present in the peripheral smear. So this is very clear cut. This is a case of leukemia.
So yes, so do we need to do any other? I actually mentioned it here.
So yes, definitely, for this evaluation of this child, we would like to do a bone marrow. We would like to do a chest X-ray, make sure there is no mediastinal mass, take this child up for a bone marrow aspiration biopsy, do flow cytometry, cytogenetics, fish studies on the marrow, do a lumbar puncture after giving platelets to make sure that, whether there are blasts or not, give intrathecal chemotherapy, and the whole leukemia workup, it's a topic on its own. So all that has to be initiated. And I think the message is that most leukemias are curable and lymphadenopathy is a manifestation. So don't just treat every lymphadenopathy as infection.
Okay. So, next imaging or biopsy would we don't need biopsy, I guess, in this. So in next imaging would be, as you said, leukemia. For leukemias, we'll start investigating. I think I'll take questions because we already are over time. It will be a good thing to do. So I think first question is role of applications of biopsy. Dr. Saha, will you take this question?
Yeah, can you repeat the question, Monica?
The role of FNAC and indication for a biopsy, for a lymph node enlargement.
Yeah, so it is, I think Dr. Hiren already touched, because the architecture and the biopsy, and not only the biopsy, the further immunohistochemistry, everything is possible, particularly you can say in our hospitals, though few centers are confident enough to do with the FNAC, but I think we should prefer for the going for a biopsy. It is a gold standard rather than the dependent on the FNAC.
Okay. Dr. Shalini, you want to
I just wanted to add to what Dr. Manas was saying. And in the case, exactly what you presented. So sometimes what happens is the child has lymph nodes and is referred to the surgeon. And we're taking up the child for a lymph node biopsy. It's maybe 12, 13-year-old cooperative child. And I think I can do it under local anesthesia. So it's important to, we always send a CBC, but it's important to follow the CBC report, not only just to see that, platelets are adequate and that you're not going to have any trouble with the lymph node biopsy, but also many times it has happened that the CBC and peripheral smear have shown leukemia, just like in this case. And then the child did not actually require the lymph node biopsy. That's what I wanted to just highlight.
Okay. So next question is, what does reactive adenitis imply, usually reported on FNACs? Should we leave the kid with such a report, even in a chronic cases, or do we need to do a biopsy? Dr. Saha, Dr. Shalini, if you want to have, you both are there.
So, Dr. Shalini, I think, would be the.
She can't see her.
Okay, ma'am is
Yeah, I'm there.
Yes,
so, I mean, sometimes it's very difficult to interpret the reactive lymphadenitis, which is reported on FNAC, especially if it has been done by some other pathologist with whom you are not able to discuss. So I would usually not go just by the FNAC, just like Soumitra said earlier, and I go more by the clinical suspicion. So if I can feel the nodes are firm, they are matted, or even if they're discrete, but they, you can feel the reactive nodes have a little soft kind of feeling, and whereas the pathological nodes, of course, the final answer is with the pathologist. But if there's a clinical suspicion, whether symptom-wise or the feel of the nodes, and whether if they're persisting at least for more than 2 weeks, or even if 4 weeks, even if you've kept under observation for 6 weeks, and then they're still persisting more than a centimeter, I would definitely go for a biopsy. Many times we have got an answer of reactive, and probably it was Epstein-Barr virus or something. But it's always, before sending off the child saying, oh, there's nothing, just based on the FNAC, I think it's too much. So whenever there's a suspicion, we must do a biopsy. If you're not doing a biopsy, please keep the child in a very close observation.
True, ma'am. So, so surgery in abdominal NHL is.
If it is tuberculosis,
Yes, sir.
if you think it's tuberculosis clinically, will you do a biopsy or will you do an FNAC? Won't FNAC give the diagnosis of tuberculosis? Because
sometimes it does.
You can avoid the scar
Sometimes
on the neck
does.
for a child, see. I feel
Definitely,
tuberculosis is more common than malignancy. And if points are more towards tuberculosis, like if you're getting something like a cold abscess or a matted gland, because you avoid the scar on the neck if it's tuberculosis. That's what I feel. Of course, if you suspect malignancy, you have to do an open biopsy, full node you must take up. But if you strongly feel clinically of tuberculosis, you first try an FNAC, and if it shows you the typical tuberculosis thing, you can avoid a scar for the child on the neck.
So your point is
Agree, sir.
your point is very right. The only issue is that often what happens is that an FNAC is done. It is reported as normal. The lymph node persists, and then nobody does anything because that FNAC, which was done by somebody, was okay. So that is the problem. If you get the answer from FNAC and you got it tuberculosis, you have started, that's fine. The problem is when you don't get the answer and the lymph node is there, we have to move to the next step. That next step never happens. And that is why, we discourage FNAC so much, because it gives you a false, safety sensation.
See, when I was young in Stanley in 83, I might have done 500 cervical node biopsies because there's a tuberculosis project going on. Okay, to tell you the truth. So quite a lot of times, it just came reactive hyperplasia. So I thought I gave scars for a lot of children unnecessarily, This is my personal feeling as a senior surgeon. So I feel like what you are saying, clinically we have to see correctly. But of course, you have to keep following the node, and first attempt we can do an FNAC, and then always, if unsuccessful, we have to definitely do a node biopsy. Other thing is, what do you think is the role of frozen section in node biopsies? The pathologists hesitate to report on frozen section, but like there have been occasions before this thoracoscopy and laparoscopy came. Sometimes there was no other node, so I have to open the abdomen or the chest to take the node for biopsy. So then I must make sure that I got the correct node, So there at least the frozen section plays an important part. What is your impression on frozen? What do you order the pathologist? They say, oh, Dr. Bagri, we cannot report frozen section on lymph nodes. So what has been your experience?
So we use frozen section only for margins, mostly for margins. Otherwise, it's
That is
very
there. See,
difficult.
madam, what I'm telling you, it happened to me
Lymph
once.
nodes. Yeah.
I opened the chest of a child because no peripheral gland was there. So there was a node. So I did not know whether it's tuberculosis or whether it's malignant. Okay. So see, no, there are so many nodes. You take out one node, whether that's representative or not, you don't know. So the pathologist told me, see, Dr. Bagri, you cannot close the chest without doing a frozen section. You have to make sure what you have taken at least is a representative sample of the thing. That's what is given even in surgical clinics of North America. So I learned a lesson that day. So definitely when you take a node from if you have to open the abdomen and chest or do a laparoscopy or thoracoscopy, if you're not sure, you have to wait for the pathologist frozen, because otherwise you open the chest, you take a node, and then the biopsy comes as reactive hyperplasia. You are left nowhere. You might have just missed the malignancy inside. So this is my personal experience, is what I feel. And what very rightly the first speaker told, that before doing a node biopsy, you must take an X-ray chest. There have been times once, a child was taken to the theater, anesthesia was given, nobody had done a chest X-ray for a node, and then, my God, the child had to go on ventilator and all that. So that's very, very important.
So usually we discuss if there's a PET CT done, and we discuss with
For
the
small nodes,
radiologist.
madam, nobody does PET CT. A child is just for node biopsy. And
but if you're
people
doing
are not aware of all that an X-ray chest is
thoracotomy
done.
or abdominal laparotomy for a node, then probably some imaging will be done. Definitely, we won't be going just based on ultrasound, especially if we are going. And in today's era of intervention radiology, most of the time we're able to do it through CT guided. It's hardly ever that I have to open an abdomen. I agree that sometimes there can be a circumstance like that, but discussing with the radiologist
No, I'm talking about the
node to
early
pick up.
80s, madam.
Yes, sir. Yes, I can understand.
I'm talking about the early 80s. I know nowadays, of course, everything is different. I'm talking about the early 80s, what it was.
But frozen has its own fallacies, and many times if they said benign on frozen and then later comes malignant or vice versa, and so we usually don't take a lot of decisions based on frozen, especially in children. That's what I feel.
Yeah, but they will tell us whether it's malignant or not. That's what I thought. And sometimes TB and malignancy coexist. That problem also we've had, We thought it's TB and then it didn't get well and the malignancy is also there. I don't know if you've had that sort of situation, a coexistence of both tuberculosis and malignancy.
But most of our children receive some kind of ATT. That's where I see the children, they come. Everyone, most of them, I think 90% of children with lymph node receive some kind of treatment related with the antitubercular treatment. Then they come when it's not clearing the nodes and it is increasing rather.
So any more questions? I mean, there's one question. What is the role of splenectomy in reducing the bulk of disease for chemotherapy? I think it is about NHL.
I think
there's no role.
It is it is there at once, but now it is obsolete, this thing.
Okay, and so complications or morbidities basically of abdominal lymph node biopsies for NHL. So what is the experience, Dr. Saha, Dr. Shalini? Because I think they've mentioned 10%, maybe some perforation was there in a patient.
Oh, well, I think it again depends that I've hardly gone in and done a lymph node biopsy, abdominal biopsy of late. I mean, unless there was a perforation already. I mean, that is the time when I've gone, or there was a peritonitis, or there's some problem with stricture. So I have not found a lot of complication because mostly it is done by IR team in our institute.
Okay. So I think there are no more questions.
Is Dr. Hiren listening there? Is Dr. Hiren there?
Yes, Dr. Hiren is there.
See, of late, when whenever we send ultrasound abdomen for abdominal pains and all, mesenteric lymphadenitis is reported so often by the sonologist.
Yeah. So
So the mesenteric lymphadenitis, I would like you to tell some more points, to the audience, because it's one big thing, whether it's really important, when you should consider mesenteric lymphadenitis as important.
Yeah, so as I was mentioning that when you see cluster of lymph node more than 4, 5 in one region, and if the size of the lesion is more than 0.8 centimeter, then you should consider it as a abnormal or mesenteric lymphadenitis secondary to infection or whatever. But if you see that the nodes are scattered, they are small oval shape with normal homogeneous appearance, and they are not clustered in one location, then you should not take it as a abnormal thing, because they are seen in all normal patient also, normal child also. So that's the thing.
Thank you.
Okay. Thank you, everyone. Thank you, Dr. Shalini. Thank you, Dr. Bagri, sir.
It was very nice, madam. Very good meeting. I think the pathologist also you should have called, it would have been very
I
nice.
realized later on that pathologist is missing. So, but actually everybody.
Some other day you can call the pathologist, because finally it's not final diagnosis of the pathologist.
Yes, sir. So next time I won't miss calling a pathologist in the panel at least.
It was very good. Thank you.
Thank you.
Thank you,
Dr.
everyone.
Hiren.
Thank you,
Thank you, everyone.
Monica.
Thank you, Dr.
Thank
Saha.
you, ma'am, Shalini, ma'am.
Thank you.
Thank you.
Thank you
Thank
so
you,
much,
Rupsa.
everyone. Thank you so
Yes.
much, ma'am. Thank you so much for extending us the opportunity to host the session. And I hope you had a seamless experience. So with all your permission, I'm signing off here and looking forward to host you again. Thank you so much. Good night.